Hello, and welcome to the CHEST Journal Podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Hi, everyone. Welcome to this edition of the CHEST Journal Podcast. My name is Matt Siuba. I'm a critical care doctor at the Cleveland Clinic in Cleveland, Ohio. And I have the pleasure of talking to Dr. Stephanie DeMasi about a really interesting paper that'll be coming out in the journal called Oxygen Saturation Targets and Neurologic Outcomes Following Cardiac Arrest, a secondary analysis of the pragmatic investigation of optimal oxygen targets trial. So first of all, Dr. DeMasi, Stephanie, thank you for joining us today. I'd like to just have you give us a brief introduction of who you are and where you work.
Yeah, thank you so much for having me. I'm really excited to be here and talk about this study. I'm Stephanie DeMasi. I am an emergency medicine faculty here at Vanderbilt University. I did my ER training at UAB in Birmingham, Alabama, and I came to Vanderbilt to learn pragmatic acute care clinical trials under my mentors, Wes Self, Matt Semler, and John Casey.
Fantastic. And certainly no better place to learn about pragmatic trials than where you are right now. So let's get right into the background of this study. What did we know about oxygenation targets and cardiac arrest going into this study, and specifically how do those targets affect neurologic outcomes?
Yeah, so there are decades of preclinical data that suggest a lower oxygen target may be associated with improved neurologic outcomes in survivors of cardiac arrest. However, clinical research and really by way of a number of clinical trials have generated conflicting evidence, which has led to a little bit confusion. And our guidelines, from the AHA or ILCOR essentially state to avoid the extremes, avoid hypoxemia and hyperoxia after arrest, although they acknowledge the very low or low certainty of evidence.
What specifically inspired this study question?
So there's a strong physiologic rationale after cardiac arrest that patients may be particularly vulnerable to ongoing brain injury. That is to say, hypoxemia may worsen hypoxic ischemic encephalopathy, otherwise sort of termed a secondary brain injury, whereas hyperoxemia may causes cerebral vasoconstriction, which creates additional reactive oxygen species and may lead to further injury. And because of this lingering uncertainty, this was a pre-specified subgroup in the pilot trial.
Great. And speaking of the pilot trial, can you give us a basic overview of that trial since we're working with a subset of patients from that?
Yeah, absolutely. So the pragmatic investigation of optimal oxygen targets, or the pilot trial, it was an unblinded, cluster randomized, cluster crossover trial that compared the effects of lower, intermediate, and higher oxygen targets on ventilator-free days and in-hospital mortality among critically ill adults receiving mechanical ventilation and enrolled at a single academic medical center. And I'll highlight that in this trial, the cluster crossover meant that the whole ICU was randomized. The ICU was our cluster and enrolled everyone on the vent in the study unit as soon as they arrived in the unit. And that included, every survivor of cardiac arrest who came into the medical ICU. And because the whole ICU crosses over, i.e. switches their oxygen target in random order every 2 months, the trial's statistical power is much like a patient-level randomized trial.
That's really interesting, and it calls back to some of the fluid studies that were done by your group in the past that were also really interesting, and a really great way to try to study really important questions that we deal with every day. So now that we kind of have an idea of the background and what this cohort looks like, what's the basic overview of the study design for this paper?
So this was a pre-planned subgroup analysis of pilot, meaning that we hypothesized that having a cardiac arrest may affect the intervention, and in this case, the oxygen target on the outcome. And so for this study, all patients in pilot were screened for inclusion. Those that had a cardiac arrest with sustained ROSC were included in the analysis. And for this study, we made an important change. We reduced the 3 trial groups in pilot, the lower, intermediate, and higher, into 2 groups in order to compare lower or intermediate target, which was 88 to 96%, versus the higher oxygen target, which was 96 to 100%. And our rationale or our thought process here was that for patients after a cardiac arrest, we hypothesized that hyperoxemia would be harmful, again, through that same hyperoxia-induced cerebral vasoconstriction mechanism. Therefore, we designed this study to test whether a strategy of avoiding hyperoxemia, which was the goal of both the lower and the intermediate groups, would improve outcomes compared with a strategy that was not designed to avoid hyperoxemia, the higher oxygen target group. And the primary outcome of our study was favorable neurologic outcome, which we defined as a CPC of 1 to 2, or cerebral performance category. And this is one of the 2 most commonly used categorization of neuro outcomes after cardiac arrest or in brain injured patients, modified Rankin scale being the other one. A CPC of 1 is normal. It's described as your patient being conscious, alert, able to live a normal life. And a CPC of 2 is moderate disability, but described as your patient being conscious, but they may require some assistance. So a CPC of 1 to 2 at hospital discharge has been shown to be predictive of longer-term functional outcomes, which ultimately is the desirable endpoint. We want to know the intervention improves our patient outcomes both at the time that they leave the hospital, but also is sustained at a later time point after.
Great. Thank you for that overview. And so now that we understand sort of our groups and how they're composed and the outcomes, we ended up with just over 300 patients to study in this trial. What were the key takeaways?
Yeah, you're exactly right. So of the nearly 3,000 patients in pilot, there were 339 that met our inclusion criteria, were included in the analysis. Our group included patients with a median age of 60, just under half were female, over half had an in-hospital cardiac arrest, and only 10% had an initial shockable rhythm. So the primary outcome, the key takeaway was that favorable neurologic outcome, again defined as CPC 1 to 2, occurred more often in the lower or intermediate target group. It occurred in about 23% of this cohort compared to the higher target group, which only had a favorable outcome in about 13%, which was an absolute risk difference of 9.9%. And the odds ratio was similar in an adjusted analysis where we controlled for several cardiac arrest specific baseline variables. And then secondarily, the secondary outcome of death by day 28 was numerically different. It was 66% in the lower or intermediate group compared to 75% in the higher group, but this was not statistically significant.
Thank you for that overview. So seems like the hypothesis that drove the creation of the study was more or less confirmed and all candor kind of favored my priors as well. Knowing that now, what words of caution do you have for readers in interpreting these results in terms of any limitations or things we need to consider?
So this study, as stated, included only a small subset of the total pilot trial population of 339 patients. Further, due to the pragmatic trial and the data being available from the EHR, this sort of limited what we had in terms of baseline characteristics. So we did not have things like CPR quality to include in our baseline analysis. We did collect cardiac arrest specific baseline characteristics like the witness status, whether bystander CPR occurred, the initial rhythm, which were ultimately used during the adjusted analysis. Number 2, this trial enrolled patients from a single center. So we had a high proportion of patients with an in-hospital cardiac arrest and without a shockable rhythm, which distinguishes these data from some others. And overall, we had high internal validity, with regard to separation between groups and adherence to group assignment, which is what's depicted in Figure 2. However, the external validity is limited by this trial being conducted at a single center. And finally, an important limitation to mention is the CPC outcome was assessed by EHR review, which has been previously reported and validated, but it may have limitations and may have had some mischaracterizations when compared with a CPC that is done by a prospective research staff personnel.
Great. Yeah, I think those are all really important considerations. So now that you have this data, which more or less confirmed your hypothesis, some of the prior data that you mentioned towards the beginning of our discussion was maybe a little more mixed. How do you think clinicians should think about oxygenation targets after cardiac arrest now? And does anything about what you found in your trial change your clinical practice?
Yeah, that's the key question. So, given these data that demonstrated a lower intermediate target resulted in improved outcomes for our patients, and that they were collected at a center that I practice clinically, and that they're associated with very little cost and effectively not been shown to cause any harm, they've informed the care of my patients. However, applying this more broadly, for example, like outside of this institution, may cause an understandable hesitation as we await more data.
Speaking of more data, I know there's mentioned in the discussion of this trial, there's a couple of trials that are currently in progress that may explore this question a little further. Either thinking about one of those or coming up with a trial off the top of your head, what do you think an optimal prospective design would look for to try to verify these results?
Yeah, so interesting stuff coming in the pipeline. MEGAROX is a massive trial of oxygen targets that will include about 40,000 patients. And in this trial, they have pre-specified a subgroup of patients with suspected brain injury following a cardiac arrest. They call it the MEGAROX HIE. And we are very much looking forward to these results that will no doubt be impressive just by the sheer numbers in and of itself, but also certainly going to inform care. And then in thinking about other future work, as we know, not all ICU patients are the same, not all ED patients are the same, certainly. And not all cardiac arrest patients are the same. And perhaps there are some patients that may benefit from a higher oxygen target, whereas other patients may benefit from a lower oxygen target. And to investigate this further, we're developing a machine learning algorithm that takes patients' baseline characteristics and it uses them to predict which oxygen target they would benefit. That is to say, a quote, personalized oxygen target. And we're interested in assessing how this personalized target would compare to usual practice. So that is coming down the line for us, and much more to this effect to come. Stay tuned.
That is a great overview. Thank you. I'm really excited to hear the results of this personalized work that you're doing with machine learning to back it up. I'll be on the lookout for that. Anything else that you want to share or bring up today as part of our discussion, or any take-home points for the audience?
I think we covered it. I don't have any extra tidbits. Really appreciate this opportunity. Thank you so much.
Well, thank you, Stephanie. Great to have you. This was, again, we're talking about the article, Oxygen Saturation Targets and Neurologic Outcomes Following Cardiac Arrest. It's a great read. Check it out. Thank you, Dr. DeMasi, for joining us today. And to the audience, we'll see you next time.